Ever wake up just feeling totally exhausted, even after what felt like a full night? Or maybe your partner mentions your snoring sounds a bit dramatic.
Yeah, like sawing logs, but with weird pauses.
Exactly. Today we're doing a deep dive into obstructive sleep apnoea, OSA for short. It's basically where your breathing repeatedly stops and starts while you sleep.
Right. And our mission today is really to give you the high-yield stuff, the core facts you need on OSA, clear and simple.
We'll cover what it is, the causes, risks, how doctors figure it out, and importantly, how it's managed.
Spot on, all the essentials.
Okay, so let's get straight to it. What exactly is obstructive sleep apnea? Define it for us.
Well, it's all about repeated blockages in your upper airway while you're asleep. These blockages lead to pauses in breathing or sometimes just really shallow breathing.
How does that happen, like physically?
Essentially, the muscles in your throat relax, maybe a bit too much, and they collapse, narrowing or even closing off the airway. This messes with your breathing and causes these little awakenings.
Awakenings you might not even remember.
Often, yeah. You don't fully wake up, but it fragments your sleep badly.
You mentioned pauses. Are there specific terms for those?
Uh-huh. An apnoea, that's A-P-N-O-E-A, is when breathing stops completely for at least 10 seconds.
10 seconds, wow.
Yeah. And then there's hypopnoea. That's where your airflow reduces by at least half. Again, for 10 seconds or more.
Hypopnoea, got it.
And the key thing is, these events can happen over and over, sometimes hundreds of times a night. That's what disrupts sleep and leads to feeling wiped out the next day.
Okay, so it's not just snoring. What are the root causes then? Why do those muscles relax so much?
That relaxation is the main mechanism, but there are factors that make it more likely. Sometimes it's just anatomy, maybe a naturally narrower airway or big tonsils getting in the way.
Makes sense. What else?
Obesity is a really big factor. Extra soft tissue around the neck can physically press on the airway when you lie down.
Ah, okay.
Also, sometimes it's down to weaker throat muscles or even how the brain controls those muscles during sleep. Neurological control, basically.
Any other triggers? Lifestyle things?
Definitely. Smoking is known to worsen it. Alcohol, especially in the evening, relaxes those muscles even more.
Right, I've heard that.
Certain medications, like sedatives, can have a similar effect, and sometimes it just runs in families. Oh, and even a blocked nose can contribute.
Interesting. So who's most at risk? Can we paint a picture of the typical person who might develop OSA?
Well, there are some clear risk factors. Obesity, as we said, is probably the biggest one.
Right.
Age plays a part too. It gets more common as people get older. We tend to see peaks in men around, say, 55 to 59, and women maybe a bit later, like 60 to 64.
So it affects men more.
Historically, it was thought to be mainly men, but we now know it affects plenty of women too, though it might present differently sometimes, and family history is definitely a risk.
You mentioned anatomy before. What sort of physical things should we look out for?
Yeah, things like a large neck circumference, more tissue, remember? A naturally narrow airway structure, and large tonsils or adenoids, even having a large tongue, which is called macroglossia.
Macroglossia, okay.
And then there are those lifestyle factors again. Smoking, drinking alcohol, using sedatives, even chronic nasal congestion forcing mouth breathing.
You also mentioned other medical conditions.
Yes, certain conditions are linked. High blood pressure, diabetes, especially type 2, heart disease, an underactive thyroid, acromegaly, even things like Down's syndrome or Marfan's.
Wow, quite a list. It really highlights the connections in the body.
It does, and underscores why getting it diagnosed is important.
Going into partners, you said their observations are key.
Absolutely crucial. Often, the person with OSA is the last to know about the breathing issues. It's the partner who hears the loud snoring, the pauses, the gasping or snorting sounds when breathing starts again.
That must be alarming to witness.
It really can be. Those witnessed apnoeas are a major red flag. If someone's partner is reporting that, it definitely needs checking out.
Okay, so someone has the symptoms, maybe their partner is concerned. What happens next? How do doctors actually diagnose OSA?
It usually starts with taking a thorough history, asking about snoring, those witnessed breathing pauses, daytime sleepiness, morning headaches, maybe even waking up choking or gasping.
Are there specific criteria?
Yeah, generally, if you tick 2 or more boxes from a list, things like snoring, witnessed apnoeas, unrefreshing sleep, daytime fatigue, concentration issues, waking up needing the loo a lot, gasping, then an assessment is recommended.
What about urgent cases?
There are definitely times for urgent referral. A very high score on a sleepiness questionnaire, like the Epworth scale, say over 18, or if someone's had a road accident possibly linked to sleepiness.
Right, that makes sense. Safety first.
Exactly. And certain groups need urgent assessment too. Professional drivers, people with unstable heart conditions, pregnant women, or someone about to have major surgery.
What about a physical exam? What might the doctor look for?
During the exam, they might note things like obesity, check the neck size, look inside the mouth and throat for obvious obstructions like large tonsils or small jaw, and check the nasal passages.
And then come the actual tests, the sleep studies.
Correct. The gold standard is called polysomnography, PSG. It's usually done overnight in a sleep lab.
Sounds intensive. What does it measure?
It tracks a lot. Brain activity, eye movements, muscle tone, breathing effort, airflow through your nose and mouth, blood oxygen levels, heart rate. Gives a really detailed picture of your sleep.
But I've heard you can sometimes do tests at home.
Yes, that's becoming more common for certain patients. It's called home sleep apnea testing, or HSAT. It's more convenient, measures fewer things, but focuses on breathing, oxygen, and heart rate. Often a good first step.
And these tests give you that AHI number, right? What's that about?
Right, the AHI apnea hypopnoea index. That's the key metric. It's the average number of apneas and hypopneas you have per hour of sleep.
Okay, and how is that graded?
It tells us the severity. An AHI between 5 and just under 15 is considered mild. 15 to just under 30 is moderate. And 30 or more per hour is severe.
Mild, moderate, severe, based on the number per hour.
Exactly. And interestingly, guidelines often suggest starting with a home-based respiratory study first for suspected cases.
We touched on associated conditions earlier, but maybe we can list the big ones again. It seems important for understanding the broader impact.
Absolutely. Untreated OSA isn't just about feeling tired. It's strongly linked with high blood pressure, coronary heart disease, stroke, heart failure, and arrhythmias like atrial fibrillation or AFib.
So major cardiovascular risks.
Definitely. Also, metabolic problems,
Yes.
obesity itself, metabolic syndrome, and a really high prevalence in people with type 2 diabetes.
Any others?
Yes, it can worsen asthma. It's associated with PCOS in women, Down syndrome, a specific type of optic nerve damage, hypothyroidism, and acromegaly, too. It really has wide-ranging effects.
Okay, so diagnosis is made. What does management look like? Is it just the CPAP machine?
CPAP is a cornerstone, especially for moderate to severe OSA, but management is usually broader and tailored. Lifestyle advice is almost always the first step.
Like what?
Weight loss is huge if the person is overweight or obese. Even a modest reduction can make a difference. For severe obesity, sometimes bariatric surgery is considered.
Makes sense, reducing that neck tissue.
Precisely. Also, stopping smoking, avoiding alcohol, particularly close to bedtime, and steering clear of sedatives if possible. If nasal congestion is an issue, treating that with sprays or sometimes seeing an ENT specialist can help too.
And then there's CPAP. How does that actually work?
CPAP stands for continuous positive airway pressure. You wear a mask over your nose, or sometimes nose and mouth, connected to a machine. It gently blows air into your airway, keeping it open, like a pneumatic splint.
Does it work well?
It's very effective when used correctly. The recommendation is usually at least 4 hours a night, ideally all night. But compliance can be an issue. Some find the mask uncomfortable or feel claustrophobic or get a dry nose.
So it needs some getting used to. Are there alternatives if CPAP isn't working out?
Yes. For mild to moderate OSA, or if someone really can't tolerate CPAP, mandibular advancement splints, or MAS, can be an option.
What are they?
They're like custom mouth guards you wear at night. They push your lower jaw slightly forward, which helps pull the tongue forward and open up the airway space behind it.
Any downsides?
They can sometimes cause jaw discomfort or bite changes, so they need proper fitting and follow-up.
What about people whose OSA is mainly when they sleep on their back?
That's called positional OSA. For them, positional modifiers can help. Simple things, sometimes even sewing a tennis ball into the back of pajamas to make sleeping on the back uncomfortable.
The tennis ball trick, I've heard of that. Does it work?
It can for some, yeah. Encourages side sleeping.
Is surgery ever an option?
Surgery is usually considered if other treatments haven't worked or aren't suitable. There are various procedures, things like UPPP, that's uvulopalatal quite a mouthful, which removes some throat tissue.
Okay.
Tonsillectomy can be very effective, especially if large tonsils are the main problem and the person isn't significantly obese. More complex surgeries exist too for severe cases.
It sounds like there are quite a few options then. What happens if someone doesn't get treated? What are the long-term consequences?
Well, as we mentioned, the risks of high blood pressure, heart disease, and stroke go up significantly.
Right.
Also, the risk of developing type 2 diabetes and metabolic syndrome increases. Cognitively, people can struggle with memory, concentration, and mood changes like depression or anxiety.
And the daytime sleepiness must have consequences too.
Absolutely, a much higher risk of accidents at home, at work, and especially while driving. There are specific rules about driving. If you have excessive daytime sleepiness, you usually have to stop driving and inform the licensing agency.
Wow. So it affects safety and quality of life massively.
Hugely.
But let's end on a more positive note. What's the prognosis like for people who do get treatment and stick with it?
Generally, it's very favorable. With effective treatment like CPAP or MAS, people usually see big improvements in their sleep quality, daytime alertness, and overall well-being.
And the health risks?
Those associated health risks often decrease too. There's even evidence showing that treating OSA in people with high blood pressure reduces their overall risk of mortality. So treatment really makes a difference.
That's really good news. So the key takeaway seems to be OSA is common. It's more than just snoring. It has serious potential health links, but it's definitely treatable.
Exactly. If any of this sounds familiar, either for yourself or someone you know, that persistent tiredness, the snoring with pauses, it's really worth getting it checked out by a doctor.
Absolutely. And for all you listeners out there, especially if you're prepping for exams or just want to deepen your knowledge, remember to check out passthemsra.com and freemsra.com. Great resources there.
Definitely worth a look.
So perhaps something to reflect on is just how interconnected our sleep health is with our overall physical and mental well-being. Recognizing even subtle signs can be the first step towards better health.